Hello everybody. It's Paul and Peter. The reason we are 2 minutes late is the indefatigable Peter has literally gone back to back in podcasts and chairing and facilitating. So we are incredibly grateful for him that he is literally without drawing breath gone from one thing immediately to the next. So a huge vote of thanks. He also has arguably after Black Lives Matter and How's It now the most adorable sign in the back done by I'm told your daughter. So you know, if you we'll keep inviting you if you keep putting on awesome signs in the background. Peter, I want to start with what I think is cautiously really excellent news, and I might mangle the name, but Dexamethasone, there or thereabouts, coming out of Oxford, not far from where you are, really interesting treatment. Tell us about it. I'm psyched to hear more.
Yeah, so dexamethasone is a steroid medication. It's been around for almost 60 years, and it's in the same family as prednisone and some other steroids that many of you may have been prescribed or know someone who has for a variety of different conditions. Not the kinds of steroids athletes take, but steroids that are common. So it's been around forever. It's cheap, and it does a lot of stuff. And there was an announcement yesterday from the team here at University of Oxford running something called the recovery trial that they had closed one arm of the study, which was really designed to look at lots of existing therapeutics and whether they might have some meaningful effect in COVID-19 disease. And what they found actually was that dexamethasone had quite significant mortality benefits, meaning it prevented people from dying in quite a robust way. So let's talk about first what the two categories of treatments there are, right? There are drugs that attack the virus itself, and remdesivir, the drug that was approved in the US a few weeks ago, a new antiviral drug, actually attacks the virus itself. Those tend to be most beneficial early on in disease and preventing you from getting to the more severe disease with pneumonia and getting really sick and needing a ventilator and things like that. At that point, what happens is actually the body's overwhelming immune response takes over and does most of the damage, that people drown in their own fluids in their lungs as there's a ton of inflammation in the lungs, the blood vessels, etc., something that's sometimes called cytokine storm. And so there have been a lot of different drugs that can suppress some aspect of the immune response, and that's exactly what steroids do. And so what was found in this study was that for patients on ventilators with COVID-19, or for patients who are already requiring oxygen because of COVID-19 disease, there was a significant reduction in deaths. And we're talking about a 1/3 decrease in patients on a ventilator and 1/5 for patients who are requiring oxygen. There was no benefit for people earlier with milder disease who didn't need oxygen. So once you've already started to kind of progress to this more sort of excited immune response, it did seem to have a real effect. That's a very significant response, and we should note that it's the first therapeutic, to my knowledge, that's shown an actual benefit in saving lives with this disease. Remdesivir shortened the duration of disease. It hasn't, at least yet, been proven to save lives. So this is a big deal, if true. And I use that caveat because there is a caveat here, right? We're doing warp speed science and things are moving quickly, and we're not sort of pausing to do the normal due diligence that we do through peer review in scientific journals and things like that. So not only has this finding not gone through appropriate peer review to kind of validate the findings, they didn't yet even release the data. So we don't know all the details about the methodology and exactly what was found. We really just got the sort of top line results. The researchers, who are extremely credible, and the study is extremely robust and credible, and the numbers are big, felt like this was so important and urgent, it was important to get it out there. And already in the UK, they've changed policy. So patients who are requiring ventilators or oxygen in many cases now may be eligible to get dexamethasone treatment. But it's just one finding. And I guess the one caution I would say is, not that I'm not really excited about this, I am, and we all should be. Steroids have been tried for every kind of like respiratory viral disease you can imagine, and the track record has always been pretty mixed. It's also been tried for acute respiratory distress syndrome, the kind of lung breakdown that we see with severe COVID-19 disease. It's never shown to be so unequivocally beneficial. Sometimes it was a little more harmful than it was helpful. Oftentimes it was just a mixed picture. So there's a little bit of surprise in the finding, and it's a happy surprise, but we know that sometimes, the results of one experiment doesn't hold up. So I think it is going to be important to be cautious in our optimism. It's really important for the researchers to release their data as quickly as possible so others can look at it and interrogate it. There's a lot of nuance. And I think it'll need to be replicated elsewhere. But in the meantime, it is being used to save lives. Last thing I would mention about this that makes it really exciting: remdesivir, brand new drug, not in wide circulation, probably going to be really expensive early on, right? And if we think about the way that COVID-19 is accelerating in Latin America, in some parts of Africa, in South Asia, dexamethasone is everywhere. Most of the hospitals I worked in Rwanda and Haiti and lots of other places often stock that. So this is a cheap, ubiquitous medication. So if it does what we're told, this could be very significant.
And now it's cheap, it's ubiquitous, relatively cheap, largely ubiquitous. And does this hold promise? I mean, I guess one of the questions I have is, if it's been this ubiquitous, why have we taken this amount of time to kind of stumble upon it? I mean, I'm sure you have some very good clinical reasons for that, but it seems like this cheap, readily available, tested, ubiquitous drug sitting under our noses. The data says that 5,000 people would be alive today in the UK if we'd been using it there or thereabouts. I mean, this is huge in terms of loss of life. I mean, 5,000 husbands and wives and grandparents, and this is a huge number. Why is it taking so long to find it?
Yeah, so what's interesting is that if you think about this, is there risk in suppressing the immune system, the very system that fights infection when somebody has an active infection, right? So there's real risk in doing more harm than good. We're very careful about using steroids and any kind of infection, because if you weaken the body's ability to fight that infection, it could get worse. In fact, I would wager that if somebody were to take dexamethasone or another steroid early in a COVID infection, it might actually increase the risk that they get a lot sicker. And so we should be really careful to warn everybody that don't take this medicine if you have mild disease. It could actually make things worse. And when we've looked at this for other respiratory viral infections, we've looked at this with ARDS, it sometimes actually causes more harm than good. So that's why a lot of people, it was an interesting mixed picture. Like the NIH in the US said, don't use steroids because there's some evidence, at least in similar diseases, it could cause harm. In Spain, at least in ICUs, it was something that was used really widely. So there had been a study earlier this year that showed some benefit in ARDS. So ICU doctors were using it in many of the patients who were on ventilators in Spain, to my knowledge. So it was different practice in different places because the picture was mixed, but there was a real risk of harm in an infectious disease, and that's why. And so I have to say it's a real credit to the organizers of this trial, the recovery trial, to say, let's take a whole bunch of existing drugs that we have some reason to believe might help, but let's put them in a really big, really robust study, because this can give us a more unequivocal picture. And so we're not just kind of muddling through guessing at things. They looked at hydroxychloroquine, you remember, much feted by President Trump, and tossed that out when it didn't work. They're looking at Kaletra, an AIDS drug, and other kinds of things. But it was a really elegant trial to be set up actually very quickly. And the fact that a couple of months in we're getting these results is something that, again, with caution, should be commended.
So now this is the big breakthrough. Two ancillary questions. One is there something about this that also helps us? You've spoken about it in our other conversations. pathways to understanding the pathology or the negative impacts, better medical term, you will provide us with of coronavirus. And therefore, now we've discovered this, might it be, oh my goodness, we have a portal or an understanding into some other related treatments that may help, one. Two, does it take us a little bit closer to where, by analogy, we were with AIDS, where you start finding a breakthrough, then you can say there's a cocktail, then you can do a triple cocktail, and you can start getting yourself to a point where we can live with the disease. You can't get rid of it until a vaccine comes, but we can start in a wildly accelerated way, because it took us 2 decades to get there with AIDS, begin to really tail off the mortality in a way that also will have massive social and political and economic consequences for us all. Are we much closer to that as a result of this than we were 48 hours before we knew about it?
Yeah. To the first question, corticosteroids like dexamethasone are a pretty blunt instrument. They sort of, they sort of smack the immune system almost across the board, at least what we call the T cell part of the immune system. So this is not a surgical attack on the immune response. It's a pretty blunt attack on the immune response. So I don't know that again, if the finding bears out, that it's going to give us insight into exactly which part of the immune response is driving this, or why some people might be more predisposed to going down a more difficult pathway than others. And in fact, the trial excluded a lot of people with contraindications to steroids, people with who were immunosuppressed and things like that. So there's a whole population, a subset of people for whom we really don't know. So it may or may not. There's a lot more sort of targeted medications that are also being trialed right now that may give us more insights. Second question, I think the answer is yes, in ways that could be important. So if you think about those 2 categories, you're kind of antiviral, I act on the infection itself, and the immune modulators, I act on the body's response to the infection. If you were to get one from each category in the right way with the right timing, potentially that, there could be synergistic effect. It could be the opposite, and this is going to have to be studied. But you could see a scenario in which you might blunt the infection with an antiviral like remdesivir and blunt the immune response with dexamethasone. And if you got that just right, that could even have a further mortality benefit. Again, could be the opposite of that. Only time will tell. To be clear, this does not stop anybody from getting infected. This does not necessarily, to my knowledge, stop people with early disease from progressing a bit further. But what it does do is, in people who are going to have at least moderate disease, where their oxygen levels are going to drop, appears to have a significant mortality benefit. We're talking about, at least for folks on a ventilator, what we call the number needed to treat is 8. That means for every 8 people on a ventilator who receive this, you save 1 life. So that finding bears out, that's really significant. And, maybe it changes the calculus a little bit if we can make this disease a lot less deadly than it is right now. Doesn't take away some of the long-term effects and other kinds of things that we're still grappling with, but obviously very exciting.
So let's pivot to the US right now. I mean, I kind of listen to, as fastidiously as I can, everything that Don McNeil, New York Times kind of health writer, who's been, I think, almost unflailingly correct in his analysis. I wonder if you agree on he was when Wuhan first emerged, he was saying this is going to be a very big deal. It'll have global repercussions. And so there was a podcast on The Daily yesterday in which he basically was going, I am petrified by a second wave in the US, partly because of the spiking infection rates in some states. Secondly, because of all the pandemic evidence we have about second waves happening in the winter. And third, proximity, indoors, something about the cold that also facilitates this. So how concerned, as we begin to sort of emerge, how concerned should we be about the second wave? And I'm sorry to ask the downer question after just having had a rather hopeful one for the first 20 minutes of our conversation.
Yeah, so I mean, Don McNeil's been a global health reporter for many, many years at the Times, and so he has I think had a much more sophisticated take than a lot of other journalists, over throughout this pandemic, and so I do agree he's been a really good source of information and insight, and I think he's right to be worried. So first, what's the situation in the U.S. right now? Right, the situation is not good. We've talked about, and everybody knows about, the kind of shambolic response at the federal level, the fact that the US has had the highest number of deaths, that there are still 20,000 cases a day and 1,000 deaths per day, and everybody's been sort of getting back to normal. That's almost been kind of something people have become numb to a little bit. What we've seen over the last week or two is that in about 22 or 23 of the 50 states, the number of cases are rising, as we predicted they might when you open back up without actually having transmission under control, but quite alarming degrees, in particular in places like Florida, Texas, and Arizona, where they're all seeing literally record case totals day after day over the last several days. And so things are inching towards that kind of exponential growth, scary phase that we saw in some places early on in the pandemic. And unfortunately, those numbers are, at least by some political leaders, being met with a shrug, saying, it's actually not a real increase in cases. It's just that we're testing more. And if you look deeper at the numbers, all evidence suggests that that's just not the case at all, that we're actually really seeing an acceleration of transmission. And so it's going to get worse before it gets better. And we know we've talked lots about these lags, right? So we know that a couple of weeks from now, we're going to see hospitals filling up much more. They're already near capacity. We're going to see deaths start to go up. So, the U.S. unfortunately is in for some more difficult times. The issue of kind of the second wave, it's not always so clear cut. And I think sometimes we've been lulled a little bit by looking at the national numbers in the US, because so many of the cases early on were New York, New Jersey, Seattle, and a couple of other places. And when those places started to flatten the curve, the overall number started to come down in the US, and it looked pretty good. Now it looks like, is a second wave coming? What we're really seeing in some ways is a first wave in other parts of the country, that just where it didn't kind of reach, maybe the middle of the country initially, where shelter in place orders slowed the entry, but now as they're opening back up at exactly the wrong moment, it's kind of just going up. What Don McNeil was talking about around the risks of a wave in the winter is very real, and it's very real for us here in the UK as well. If you look at influenza pandemics, and this is not influenza, there are lots of aspects of this virus that behave differently, for better and largely for worse. Almost every time there is this initial wave of infections that sort of we got through and was a little bit mild. And then whenever that started, the next winter hits and it comes back with a vengeance and is actually much worse than it was the first time around. In some cases, more virulent than it was the first time. We don't see this particular virus mutating, and so that may or may not be the case. But as you said, it's colder and the virus may thrive in colder conditions. We all move indoors and that increases transmission. And our health system is already overburdened in winter months because of influenza and other kinds of things. So there's a very real risk that we all need to be concerned about and working to prevent of a big wave of infections that comes in the autumn and could be quite disastrous if it were to happen. So there's a lot of reason to be worried. There's also a lot of reason to say, well, we have some time to prevent that from happening, right? We've already got the playbook to do that. We've seen countries crush the virus, suppress the virus, reduce transmission, and we know how they've done it. There's no reason we can't do it in the US. There's no reason we can't do it in the UK if we just up our game a little bit. And that's, I think, what this complacency worries me, even here to some extent. And I wish we could just be like, okay, we're going to go on the offensive here. Let's go on offense against this virus. And like, if Thailand can do it, man, so can we. If we don't do that, we're in trouble.
Well, I mean, and it does. So the contact tracing stuff, I mean, I'm so rarely speechless in my life, but the fiascos around this, the false starts, the sheer incompetence in something which is complex, but not rocket surgery. This is not
Mm-hmm.
something that ought to be that hard. So I personally have a very low level of confidence on the precise, more surgical strategy that you need. So then if you don't have that, then you have to go back to the kind of blunter, cruder stuff like 2-meter rules and, social distancing, et cetera, which are efficacious, and we know they're efficacious, but the problem is that the economic consequence, and I hold my hand up as an interested party and somebody who's in the hospitality business,
Mm-hmm.
is very, 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 very troubling, and the, numbers of people in this industry. And so you find yourself, you don't have the sophisticated precision way of dealing with it. You have to then rely on the blunt instrument, but then the blunt instrument has, enduring, scarring impact on the economy. And I find myself scratching my head to go, I'm not entirely sure. It's like asking whether you want to be shot or poisoned. I mean, it's they're not good options here.
Mm-hmm. Yeah, you're right. I mean, these things are linked, right? All the economic pain that so many have suffered was not necessarily inevitable, and certainly as we move forward, not inevitable. And so the kind of like the head scratching perversity of it all is that we, in many places, are rushing towards reopening the economy for real reasons that we feel urgency, right? To protect jobs and to protect businesses and to protect the economy. But if we're doing that in an irresponsible way, all it's going to do is multiply and draw out and exacerbate that kind of pain. Imagine what happens if we have to start locking things back down. Those are exactly the conversations that are just starting to happen in places like Florida and Arizona and Texas. The politicians aren't there, but people who follow this stuff are realizing that that's the case. One thing that's been really interesting here in the UK, if I may, is that there's been a divergence in the different parts of the UK around strategy. Here in England, I think the strategy is still a little bit unclear, like really what the objective is. What we've seen become much more visible in the last couple of weeks, but especially the last couple of days, that Scotland in particular seems to be taking a different tack. They're now, Nicola Sturgeon is saying very explicitly, our goal is to suppress the virus. We are going to try to effectively eliminate transmission. And that's going to be hard to do. But if we can do that, as we've seen in places like New Zealand, if you can do that, and then you can sort of keep yourself contained a little bit, you can open up much more normally. So you don't have to have all these kinds of really difficult 2-meter restrictions and face masks and everything else that we're setting up here in schools and in restaurants and things, if that risk is so small. And we've seen in many places, again, they have their challenges, but things are kind of back to normal. So that's very different from the UK, where we're kind of rushing to open up and tolerating a situation where we still have 1,000 or so deaths a week, and quite a number of new cases, and a high level of transmission. We're normalizing and just taking a gamble. It's not going to get worse as we open things back up. So we've explicitly diverged, and England and Scotland are now on different paths. And it also makes me wonder, well, if Scotland's successful, what happens to that border? And is it even possible for them to keep out people coming from England, for example? But just really interesting to me that this country is kind of cracking up a little bit and going different directions on their approach to the pandemic.
I mean, I spent a bunch of time in Scotland recently talking to political people there, and they kind of do think of themselves as a mixture between, Denmark and New Zealand. Population size, GDP per capita, natural resources, and also far more social democrat, so different kind of politics. So it's unsurprising that they should choose this path, and also given the scale of Scotland and the kind of population density of it, that some of these things are indeed achievable. That is not in any way to excuse the failures here, but it is interesting that it's almost predictable that they would do that path because they're more analogous to those other places. A final question: Beijing. The Chinese, there were days, if not weeks, where you didn't see a single reported infection. in Beijing. Correct me if I'm wrong, or at least reported. I underline the word reported. But we're now in a world where you see an outbreak, you see a very strong authoritarian-driven containment thereof. But I wonder if there's something that may teach us about London post-lockdown and what might be the analogies and disanalogies.
Yeah, so obviously it's a story that's still unfolding. What happened basically is that there was an outbreak that's connected to a seafood market in Beijing. The report is that there's a suspicion that frozen salmon that was imported may have been the source of infection. Theoretically possible. I'm a little bit dubious about that. I would not put too much stock into it in this early phase, and I wouldn't say stop eating salmon or stop eating frozen fish. I would say be really careful about how you handle your food and your hand hygiene when you're cooking, as you would to prevent salmonella and things like that. But there have been now about 150 or so cases in Beijing, mostly in the neighborhood around this market. And as you said, they actually created a bubble. They've essentially not quite quarantined Beijing, but you can only go out if you have permission and if you've had a test in the last 7 days. And there is kind of a lockdown in some of the districts immediately surrounding that market. So it's been an incredibly aggressive response. And I think lessons are, number one, even in a place that had this totally buttoned up and under control where there was effectively no community transmission, one ember has the potential to create an outbreak that can come back. And so for places that can get there, you still need constant vigilance and to be able to have those surveillance systems and the ability then to kind of spring onto an outbreak and snuff it out before it starts to spread is really important, especially in a densely populated megacity like Beijing or London or what have you. The other thing that's really striking is how aggressive that response has been, or New Zealand's response to 2 cases in visitors who left quarantine a bit early for personal reasons, who then later tested positive, versus our relative lackadaisical approach when we're having hundreds of cases every single day. That's interesting, but it underscores, I think, again, that even in really good circumstances where you get stuff right, this is still going to be a long road to hoe and a constant struggle, and we're going to have to stay vigilant, and we're not going to be out of the woods until, hopefully there's a vaccine.
Final word, you mentioned the dreaded V word. Just give us an update on those vaccines, man.
Yeah, so 150 vaccines under development around the world, 150 or so. New York Times started a COVID vaccine tracker, which is kind of a useful little dashboard on the number of vaccines in development and kind of which phase they are in development, that kind of phase 1, phase 2, phase 3. So if you want a snapshot, I think that's there. The front runners, as it were, are the same: the Moderna vaccine in the US, the Oxford Chattox vaccine here, a couple of others. Some of those have already gone into production on the fingers crossed outcome that they actually show efficacy, that we would be able to have access to them quickly. Dr. Fauci is still saying that there's a possibility of having an effective vaccine in circulation around the end of the year. I still think that's an optimistic projection. There haven't been big developments that I've seen in the last week, at least on those leading candidate vaccines. Sometimes no news is good news. You just need to kind of plow on with this research. So I think we continue on with our hope for the best and plan for something less than the best. We'll see where we get to.
Awesome. Peter, we're out of time. Thank you so much. The treatment front was incredibly good on an optimistic note to start with, and let's cross our fingers that we keep making progress along the way while tackling all these other more difficult and thorny problems. But as ever, thanks so much, particularly from going from one thing to the next, and we look forward to seeing you next week.
Always a pleasure. Thanks, everyone.
Bye-bye. Stay safe and stay well. Ciao.
Cheers.